Hi everyone, this is Dr. Tom from Peachtree Plastic Surgery in Atlanta, Georgia, and today I want to talk to you a little bit about breast reductions. We're going to talk about why you might want a breast reduction, how they're performed, the different techniques that we use, and kind of what's been developed along the way, and also to help you get an idea of what might be best for you. We can explain a little bit about the interplay between breast reduction and transgender surgery, which is kind of a big thing now, and how they all relate together. So come on, why don't you join me? So let's talk all about breast reduction. So why would you want a breast reduction? Or what is a breast reduction? A breast reduction is a surgery that we perform. It's very commonly performed in this country for reducing the size of someone's breasts. Now, typically when you think about plastic surgery, you think enlarging the breast. That's what we do, right? We do breast augmentations. And yeah, that is true. We enlarge a lot of breasts. However, if you're somebody or know somebody who has very large and pendulous or hanging breasts, you know how big of a deal that can be for their life. The large and hanging pendulous breasts cause a lot of problems for people. It makes it difficult to find bras that fit and clothes that feel good. It makes it difficult to perform activities that you might like, hobbies, getting physically fit. It's really hard when you have large breasts that are pulling you forward at all times. It's hard to find clothing that can support that for active people. It's also very hard on your shoulders. When you wear a bra that's supporting a lot of weight, typically the straps pull right here on your shoulders, and that can cause chronic shoulder pain and back pain. That's the other thing, back pain, neck pain. And you can imagine when I explain this to people as to why very large breasts cause back pain, it's not actually the size of the breast that causes it. It's the distance and how far off the chest they hang. And you can think about it like this. If you were to take a rope and put it around your neck so it's dangling one on either side, on the end of that rope is a bucket of water. And you can imagine it's just hanging down and how much force it would be just pulling on your neck. We call it a lever arm in physics. It's a very long distance, and it's with a breast reduction or with women with very large and pendulous or long ptotic breasts, it's very far from the chest, so it's like holding weight away from your core. And anybody that's ever done that knows it's very difficult to do, and that's where all the pull comes from. So having very large breasts is a real problem for a lot of people, so much so that insurance a lot of times will cover a breast reduction for this reason, because it causes so many problems in people's lives. And again, if you ever meet somebody who's had these problems, it's pretty clear that it's a problem. And it makes their lives very difficult, and a breast reduction makes their lives much, much better. As a matter of fact, breast reduction is the second highest satisfaction rate in all of plastic surgery. And so it's a very good procedure for what we do. So let's talk a little bit about who might want a breast reduction. Well, anybody who's excessively large, has back pain, neck pain, gets rashes under their breasts, can't find clothing that fits, has a hard time performing activities because of the size of their breasts. And there are essentially two types of people that get this surgery. There are very young people who have juvenile breast hypertrophy, who are 18 years old or even younger sometimes, and just have extremely large breasts. And why that happens the majority of the time is because of an end estrogen receptor that is too sensitive to estrogen. So in other words, the breast tissue has estrogen receptors in it that cause it to grow in response to circulating estrogen. Their receptors, for whatever reason, most likely genetic, when estrogen binds with it, it causes an overgrowth. It's just too sensitive to the estrogen molecule. And you get very large breasts, which cause all the same problems in young people that they do in older individuals. So that's one type of person that comes to us, is young people who are growing with these problems. And then there's the second type, which are older people who have put on a little weight through the years, had children, breastfed, and now their breasts have become ptotic and large, and it starts to cause back pain later in life. The surgery is essentially the same for both of them. So let me explain to you a little bit about how breast reductions are done. But to do that, you need to understand a little bit more about the breast itself. So the breast is a bag with contents. I sometimes like to say it's like a grocery bag that has groceries in it. The bag itself is the skin envelope around the breast. The actual breast gland is the contents of that bag. When you have a very large bag and not so many contents, the bag gets saggy. You can imagine a plastic bag full of groceries, but only a few, and the bag is very large. It'll hang down very low. So the goal with what we do with any breast reduction is to make the bag and the contents fit. We want skin envelope that's the appropriate size for the gland, for the contents. And that's what you see in a youthful breast. There's no extra skin, there's just breast and skin, and it's one harmonious unit. It's up high on the chest, it stays close to the chest, and that's a youthful breast. And that's what we're aiming to maintain. The breast is a dome shape. And so if you think about a dome, in geometry, the way you make a dome smaller, the outside of the surface area of a dome, is you make two ellipses. And that is the basis for what we call the Wise pattern skin resection. So remember, there's a bag and there's contents, and we treat them differently. Now we're talking about how you shrink the skin envelope, how you make the bag smaller. And these are your incision patterns. The first one, the Wise pattern, is an inverted T, sometimes called an anchor incision, and essentially it's based on geometry. The way to reduce the size of a dome is with two ellipses. You have a horizontal ellipse and a vertical ellipse. When you combine them together, you get an anchor shape, and that's the Wise pattern skin reduction. We have a horizontal ellipse because the breast can be long. A lot of times, and almost always, when you're getting a breast reduction, your breast is excessively tall or long. So if you cut the bottom out, it goes up and becomes shorter. That's what the horizontal portion of the incision is for. The vertical portion of the incision, usually breasts are too wide. So if you do a vertical incision in the center, it becomes more narrow, shrinks together. Simple geometry why we do this incision pattern. And we can move the nipple to wherever the nipple is supposed to be. Typically, we say the nipple should be at the level of the inframammary fold. When you lift the breast up where it connects to the chest and abdomen, that, if you transpose it onto the front of the breast, is where the nipple should be, even a little higher sometimes. So that's the most common and oldest skin resection pattern, the oldest way to make a bag smaller. And that is still the most commonly done procedure for breast reduction, for reducing the size of the bag, of the skin. People have figured out over time that you don't necessarily need both a horizontal and a vertical incision. You can do great things with one or the other. Elizabeth Hall Finley from Canada popularized the vertical-only skin resection breast reduction. And that's where you just take the vertical side and you bring the breast together. It forms a nice conical breast. And the advantages to that are you get to avoid an incision across the bottom. And the advantages to that are whenever you make an incision in the form of a T, it has difficulty healing right where the two incisions come together. That's uniformly true across all plastic surgery. That's why you don't see surgeons making incisions that cross each other very often, because it's always difficult to heal a three-point spot on an incision that crosses each other. So the great thing about the vertical-only reduction is that it prevents that T-junction. The downside to it is you don't reduce the vertical height of the breast. As a matter of fact, a lot of times you make it longer. Now you tuck it up, you can raise the inframammary fold with this process, and people are really good at it. Elizabeth Hall Finley's results are amazing. And this is a great resection pattern for certain shapes of breast. The horizontal only breast reduction, I think it's called the Bellasoma method, is another name for it, a trademarked name. I don't know if I'm allowed to say that, but I'm saying it. And that again, you're just reducing this, the height. That is very uncommonly performed. There aren't many people that do it, and there's a reason why. It's because it leaves you with a very long breast. It's not very common. There are good results with it, and people that are trained well to perform this type of procedure do a good job. But there's a reason that not a lot of people do it. And it's because usually there's also not only a tall breast, but a wide breast, and you want to shrink both sides. It's really hard to make a breast narrower with just a horizontal incision. So that's the incision pattern. Now let's talk about what you do with the actual contents, the gland, the bag underneath it. So we could, a mastectomy just simply removes the entire gland. We do that for cancer all the time. Well, that's not what we want to do for a breast reduction because we want to keep the nipple alive. In order to keep the nipple alive, blood has to flow to the nipple from somewhere. The main source of blood from the nipple is from the second intercostal artery, and it travels down to the nipple, and that's how it stays alive. But there's a lot of other sources of blood that flow to the nipple. And so what we discovered, and we want to keep the nipple alive, and the way we do that is by leaving a pedicle. We call it a pedicle. And what a pedicle is it's a thick chunk of tissue from the top, from the side, from the center, from the bottom. All different kinds of pedicles have been described, but it's a chunk of tissue that has blood vessels flowing through it that feed the nipple. And then we rearrange the skin around it, we bring the nipple out to where it's supposed to be, but that's how we keep the nipple alive, through this pedicle. And the different pedicle types all have different advantages and disadvantages when it comes to how the breast is shaped and how much tissue can be taken off. The two most common pedicle types are an inferior pedicle, where we leave a base at the bottom of the breast and a little tongue of tissue with a nipple attached to it, and then fold the breast in around it. The advantages to this is that that's usually the shortest route of blood flow. It's the way that blood is easiest to get to it, and it's good for very, very large breasts that you're reducing. The downside to that is you can't make it very small. That requires you leave a large chunk of tissue right in the middle of the breast, and that limits how small you can make it. So if a patient has goals of being very small, this is probably not the right type of pedicle to use. The second most common pedicle is a superior medial pedicle, and it basically leaves a tongue of tissue around the nipple coming from the second intercostal perforator and tries to spare that vessel from dissection. The advantages to this are that you can remove a lot of breast tissue around this particular pedicle. It doesn't have to be very big. So this is a great pedicle for somebody who has goals of being very small. It also tends to, in my opinion, leave a better shaped breast because it leaves all of the superior medial quadrant of breast tissue. The superior medial quadrant is the area that you want. It's the area that has cleavage. It's the area that shows an address. And so that is the area you don't want to remove. People generally don't want the tissue hanging laterally in their armpits on the outside of the breast, and they also don't want the tissue hanging very low on their breasts. But a lot of people do like that tissue on the inside, in the superior medial pole of the breast. And so this pedicle ends up leaving that tissue, which is a nice advantage to this pedicle. The disadvantage to this pedicle is that this distance from the second intercostal, which is between the first and second ribs, way up here, that blood vessel has to travel. If you have a very long breast, that distance is very long. And using this pedicle risks the nipple not getting enough blood after surgery and causing something that we call nipple necrosis, which is where part or all of the nipple dies. That's not a great complication. Usually it's just partial when it happens, and then you go through the process of wound healing and it gets better. But a lot of times it's not. And so for people with really, really large breasts, this is not a great pedicle to use. Now, if you have a very large breast and your goal is to be very small, you may need what's called a free nipple graft, where we don't worry about the vascularity to the nipple. We simply remove the nipple from the body, shape the breast how we want, and reattach the nipple as a graft. And what that means is that it's taken off the body altogether and put back on like a skin graft is, where it relies on the bed of tissue that we place it on to live. And this gives us the advantage of having the ability to remove as much tissue as we'd like, because we don't need a pedicle. We can make somebody any shape or size when you're willing to accept a free nipple graft, no matter how large you start with. The disadvantage to this is free nipple grafts don't look great. They're asensate, they never get their sensation back. And a lot of times they lose their pigment. So this is especially prominent in African American people, where that grafted nipple can become very pale, which is not usually a good look for people. It all depends what a person's goals are, and what we're able to achieve dictates the skin resection pattern and what we do with the nipple, whether it survives on a pedicle that comes from below, from above, from the side, or whether their goals necessitate us using a free nipple graft. Now let's talk a little bit about transgender surgery and how this relates to transgender top surgery. Traditionally, transgender female to male top surgery involves two different operations. One is a mastectomy, a keyhole mastectomy, where we make a small incision on the outside of the breast at the IMF, and we really hollow out and remove the entire gland through a small hole, leaving the skin and the nipple. This is pretty much what we do for cancer patients who get a mastectomy. It's essentially the same. This is great for people who want a masculine chest and don't have much breast tissue or extra skin. The skin that remains can lay down and it looks like a masculine chest. It's a great operation, but only a select number of people can get that. The second transgender operation is a double incision pattern, where it's what used to be called a breast amputation, where we simply remove the breast and cut it out as an ellipse and close it, and then put a nipple back on as a free nipple graft in the shape and location of a male nipple. This works really well for all sizes of breast and leaves you with a very masculine chest. However, it leaves a very long incision across the chest. You're trading shape for scars. Now, that's the old way of thinking about transgender surgery. The old way of thinking is that it's a very binary choice, that people are female, however they want to identify as a man, and therefore they want a fully masculine chest. Or vice versa, people are masculine and identify as a woman, and therefore they would want a feminine chest. But that's not how it works. Gender is fluid. Gender is not binary. So a lot of people have goals of having a chest that they can both choose to be feminine or choose to be masculine depending on the clothes they wear, depending on whether they want a binder. So a lot of people who are gender fluid just want small breasts, but still feminine shaped breasts. And that's what fits their gender identity best. Unfortunately, insurance and other factors haven't quite caught up with that. But to achieve something like that, we would do a breast reduction. It's not truly a transgender operation at that point. It's a reduction to create the goal that somebody wants. But no matter what that goal is, a plastic surgeon is able to create that goal for people. It may involve a free nipple graft, it may involve a different pedicle, and it may involve a different skin incision. And there are risks, benefits, alternatives, and burdens to all of those procedures, which is why it's so important to talk to a board-certified or board-eligible plastic surgeon about these operations. If you guys have a lot of questions, I've been on many social media platforms. My main hub of everything is Instagram, where I'm at Dr. Thomas Hagopian. Please follow me on Instagram. I also frequent Reddit. I am Dr. Tom PS on Reddit. I frequent the r/plastic surgery subforum and now the r/reduction subforum as well. If those guys on either forum are excellent sources of information. They are very knowledgeable. It's so impressive what they know and how their experiences and how much they're willing to share about their experiences. So I highly suggest if you're considering plastic surgery or any reduction, go on the forums and check them out. Ask your questions. They are super great. I'm also on YouTube at Dr. Tom Hagopian on YouTube. So please check it out. I hope you enjoyed this video. I'm doing this series of just different procedures, basically me talking about procedures. That way basically anybody considering me as a surgeon, they can get to listen to me and hopefully get an idea of my personality and how I view life, how I view surgery, how I view patients' goals and things. That will give them a little bit more idea of what I'm all about as a surgeon. Anyway, I hope you guys enjoyed it. If you're watching this on YouTube, please hit the like and subscribe button for more. I try to post one a week. Otherwise, I'll see you later.